much it may rupture. So they thought this type of glaucoma or pressure elevation is due to presence of blood in the anterior chamber. Actually, the situation is not, and as Wes and his group describe it in 1963, and they gave the current name for the disease, which is a neovascular glaucoma, referring to the underlying pathology, exact underlying pathology, that there is a presence of new vessels on the iris and on the angle that are obstructing, and these vessels or abnormal vessels associated with fibrovascular or fibrous tissue closing the angle, whether in its open stage or when it contracts and lead to sciatica formation. So this is very important to know that really Wes is the one who described the exact underlying pathology. So how this membrane forms or new vessel forms, we know that the retinal ischemia is responsible for about 97% of cases of neovascular glaucoma. So once you see a neovascular glaucoma, look or search for retinal ischemia. This is in vast majority of cases. And retinal ischemia either due to, for example, we know there are the common cause of retinal ischemia, the three major causes, or the most common causes, the first two causes, the diabetic retinopathy and the ischemic vein occlusion. These are probably represent more than 2/3 of cases of retinal ischemia that can lead to neovascular glaucoma. Yes, carotid artery disease or occlusion is another cause, but again, it has a unique presentation. Usually, the pressure, when it is due to retinal ischemia due to diabetic retinopathy or central retinal vein occlusion or other causes rather than carotid artery disease, you will see in these cases the pressure is sky high, as they say, or pressure is 60, 70. But when it is due to a problem in the carotid artery disease or obstruction, the pressure usually the patient presents with a lower pressure in the mid-20s, 30s, and so on. And this is due to what? Exactly. So there is less perfusion. So the pressure will not be as high as if the cause is due to diabetic retinopathy or vein occlusion. Other causes, of course, it is, it's a big list. Probably it's difficult to memorize it, but, still, central retinal artery occlusion, branch vein occlusion, sickle cell disease, ill disease, cause disease, ROP. So it's most of them, when you look to these things, are, again, they cause retinal ischemia. And, of course, intraocular tumors and radiation. So the majority of cases, as we mentioned, once you see a patient with a neovascular glaucoma, look for retinal ischemia, regardless of the cause. So there is a retinal ischemia in vast majority of cases, if not all. Yes. Michelson, in mid of the last century, he postulated that there is an angiogenic substance that lead to formation of these new vessels in response to retinal ischemia. Of course, he doesn't know what is this substance. So he said that definitely there is a retinal ischemia, and as a result of retinal ischemia, there is this ischemic retinal release or secreted or produce an angiogenic substances that lead to the formation of new vessels. Regardless of the cause, as I said, he said this is causing the neovascularization on the retina itself, on the iris, and on the angle, and other tissues of the intraocular tissues, causing this type of glaucoma also. So this took about 50 years from researchers to find out what Michelson postulated. And he said this material is the same material which is responsible for the formation of new vessels in the embryo also, but it's in a titrated concentration, normal concentration. In ischemic retina, this material or this angiogenic substances are produced in a pathological level. So they, after 50 years of research, they found that this molecule is a vascular endothelial growth factor and or growth factors. And what is the vascular endothelial growth factor? Is one of 9 non-polypeptide growth factors, and they have a high affinity or specific for endothelial cells, as well as causing their migration and mitosis, and increases the permeability of this endothelial cells. Some studies say about 50,000 times compared to histamine. So it is very strong growth or molecule to cause or to lead to these changes in the endothelial cells. You can stop me anytime, by the way, if you need to elaborate more. So what is the source of vascular endothelial growth factor? Secreted by or produced by all these cells of the body, almost, except probably the cells of the lens epithelium. So it is produced by many cells inside or in the retina. In pathological conditions, the major source of endothelial growth factor or vascular endothelial growth factor is Muller cells. This is the major source of pathological concentrations of vascular endothelial growth factor and associated with retinal ischemia. So this is very important to remember. And other studies, since they identified or researchers identified the cause of this new vessel formation, which is the vascular endothelial growth factor, they did a lot of studies to confirm it clinically, and they found that in 221 samples of the vitreous, of vitrectomized samples from patients, they found the concentration of vitreous in patients with BDR is 36 times more than non-BDR. This again indicates that this is going really related to the retinal ischemia. And they found that its concentration is more in the vitreous to be more than its concentration in the aqueous humor. In this point or this fraction of information indicating what is the main source of this pathological level of the molecule. Not only that, but also its diffusibility to the anterior chamber. And again, were they able to take a sample, a vitreous sample from patients before and after pan-retinal photocoagulation, and this is again to give us the next information, they found that the concentration after BRB is less by 75%. They want to tell us that VEGF, or vascular endothelial growth factor, plays a major part in mediating active neovascularization in patients with ischemic retinal diseases. Is it clear? Yeah. So BRB here, we have to keep it in mind, associated with much decrease. When you do a proper BRB, the level of VEGF in the vitreous goes down to 75% or even more after BRB, indicating that really, and we see, and this is why we see after BRB elimination or fading of the new vessels on the iris and on the retina. So this is very important. This is a very respected journal, as you know. So VEGF, again, found to be elevated, markedly elevated in the abnormal levels of vascular endothelial growth factor, indicating the presence of molecules associated with the formation of these new vessels. Since that time, once they discovered the molecule that's responsible for this MVG and other, of course, other problems in the retina and so on, the research continued to find an antidote or an antigenic molecule that can inhibit secretion or production or neutralize its presence in the eye to prevent the complication of its pathological levels. So they, of course, as you know, on the market now, or there is something and not in the market yet in the science, but as you are more familiar with these molecules more than me. So these molecules, they change the picture of how do we deal with neovascular glaucoma as well as with retinal problems due to retinal ischemia. They change the picture totally. So, yeah, okay. I'm doing things, you know. Photocoagulation, upregulate expression of certain molecules like transforming growth factor beta, which is found to be a very potent vascular endothelial cell proliferation inhibitor. Not only that, but also they found that barretinol is a very potent inhibitor for new vascularization in the eye. So BRB, not only, as we'll see later, not only destroying the source, but also secreting or enhancing the tissue or the cells, retinal cells, to produce or regulate certain antidote or natural antidote to the molecule of vascular endothelial growth factor. So what are the benefits of barretinol photocoagulation? As we mentioned, it is destruction of the source of this molecule, so changing or converting the hypoxic retinal cells and retinal tissue to anoxic retinal tissue. And at the same time, with this, what we are doing, we found that when we do such a thing, this is associated with upregulation of certain anti-angiogenic factors like TGF and beta and BDF, or pigment epithelial derived factor. So these are three major benefits. You are not giving the appropriate treatment for this bad disease. So the diagnosis of neovascular glaucoma is very straightforward in vast majority of cases. You are in the emergency room and a patient presented to you in the emergency room with acute congestive glaucoma. It's very simple to isolate this type of different types of acute congestive glaucoma and to diagnose it. And the hallmark in this disease is the presence of new vessels, especially, of course, when you take the history of diabetes, history of uncontrolled systemic disease that can lead to retinal ischemia, history of vascular occlusion or whatever. So, and then when you look to the patient, you will find if the media is good enough to see the iris, oh, come on, you will see the new vessels on the, usually most of the time, the location of the new vessels is near the pupillary area. Sometimes you might find the pupil is a secluded pupil and there is no aqueous moving or more in this at the pupillary border, and there is surgical BI or whatever. You'll find the new vessels at the contact of the aqueous humor with the iris tissue. So this is the hallmark of the disease, and the patient usually comes complaining of reduced vision, severe pain, injected eye, and the pressure is always high, 60, 50, 70, in this range. Unless, as we mentioned earlier, the underlying pathology is not the usual ones. And you'll find not always the mid-dilated pupil and non-reactive, not because of the ischemia as we see it in acute primary glaucoma. Not only that, but also because of the fibrovascular tissue which is around the pupil, preventing the pupil from the normal movement. But again, definitely the elevated intraocular pressure, as we see it, or lead to ischemia and neovascular glaucoma, as we see it also in acute primary angular glaucoma. And of course, as we mentioned, the rubiosis is the hallmark, but sometimes you need to keep this in mind. In about 10 to 12%, you may not see the MVI, but when you do gonioscopy, you can see the MVA, new vascularization at the angle. This is about in 10 to 20 to 12% of cases, probably MVA or new vascularization at the angle appear before the appearance of the a new or rubiosis aridus. So you have to keep this in mind. Yes, sometimes you see it most of the time, the patient, when he comes, the media is not clear to apply what you are saying. Yes, you can apply sometimes if the media is not clear, but usually, in most cases, the rubioses are large enough to see them. But again, sometimes with high pressure can collapse these vessels. As I told you, the vessel wall is abnormal. It's easy to collapse. It's easy to rupture it also. So probably you need sometimes to give something to minimize the edema or the corneal haze by edema, giving whatever, that can help. Or you can even give the treatment and check again after, say, an hour or whatever, as you will see later on. Anything in this regard? So regarding the management, as I say, the diagnosis is very easy, but the management is not easy. 3-4 decades ago, the father of ophthalmology, Dick Elder, said that inoculation is the only practical treatment for neovascular glaucoma. And honestly, I lived that era. During my residency here in this hospital in the late 80s, when we see a patient with neovascular glaucoma, we don't have, or at least the conception that we're going to talk about it later on is not in our mind, or at least probably it's neglected from us. So I remember that what we are able to do in our hands is to go and do retinal cryoablation, and in the same time we do cyclocryotherapy to make the eye, or to reduce the pressure and to make the eye more comfortable or less painful. And a significant number of these eyes I did. I'm one of those who inoculated many eyes because of neovascular glaucoma, uncontrolled neovascular glaucoma. This was in late 80s and early 90s. So he said that inoculation is the only available option to get or to treat the neovascular glaucoma. Grant also, in the same era, also he said that there is known means to prevent development of a neovascular glaucoma. I think this is out of date now, but we need to know what is our history to know what we are now, or where we are now. Again, Hoskins, he said treatment of a neovascular glaucoma is disheartening issue. So this is 4 decades ago, not far away. So we need to remember that. So since that time, and in the early 90s or late 90s and in the last 2 decades, the outcome has improved dramatically of patients who with neovascular glaucoma, the vision-wise and keeping their eyes or minimizing our need to go and remove the eye. So, and this is because the better understanding, as we mentioned earlier, of the underlying pathology, or what the mechanism of formation of these new vessels. So this, or angiogenesis, this is very important. In addition to the availability of medical and surgical approaches, but the main thing that changed the picture of patients with a neovascular glaucoma dramatically is the understanding of underlying pathology, the mechanism of the formation of or the development of a neovascular glaucoma. This is the main issue, this is the mainstay, or this is the most important thing, that we started to understand how the neovascular glaucoma develop and other diseases, of course, and now we are pointing or referring our efforts to the underlying pathology. Yeah, I brought this statement from an article I came across when I left KKESH. I worked here about 5 years on the board, and then I get an offer from university. I went there. So I read this article by Flanagan and Black or whatever, which was reported long time, in 1983. They discussed their experience with the 3 cases, as far as I recall, of neovascular glaucoma. And what they have done, they ablated the retina by laser photocoagulation, what we are doing now. And then the vessels disappeared totally, and they treated the glaucoma as an ordinary glaucoma. So they say they came with the conception, which is very important. If the neovascular element can be removed and further neovascularization prevented, then we are left with an uncomplicated angle closure problem, which should be amenable to classical trench surgery. They mean trabeculectomy, tube surgery, whatever. So I took this article. That time in the university, the retina people was Prof. Asrar and Prof. Amro at that time. And they said, I'm interested in this article. I would like to help me to go and adopt this approach. And they said, okay, so we organized a prospective study to conduct a prospective study, taking the patient with neovascular glaucoma, treating, before we touch them, the pressure they come usually present with high pressure, and we do either tube surgery or trabeculectomy with, once we do the BRB, or even before we complete the BRB, because the pressure we cannot tolerate is very high. So we said, well, let us adopt this approach. And they said, okay, so we'll come over to that, by the way. I will not discuss it now. So how do we manage it now? What is the management of a neovascular glaucoma? Prevention, الوقاية خير من العلاج, always is the best approach. And how can we do that? By recognition of patient or those who are at risk to develop neovascular glaucoma or to develop a neovascularization. We know those patients at risk. It is very well known to us, all of us. They are well known to us. PDR patients, ischemic retinal vein occlusion, carotid artery disease. So vast majority of those patients at risk are well known to us. So we need to pay more care for them, more attention to them, so we can not only treat their MVG, but also treat their underlying pathology. So, and this can be done by correction of the underlying pathology. Patient with ischemic, طبعا you say, what can I do? What shall I do for a patient with ischemic retinal vein occlusion? At least, if you cannot do anything, watch the patient, correct his systemic condition not to happen in other areas, and take the patient, give him a programmed schedule that you need to look to his, when he comes to you, to look carefully to the area that you need to look and you know what is it, this area, the area of the pupillary area, the angle, and so on. So I'm sure we can, sometimes we miss MVI because we are quickly examining and so on. But if we are bringing this patient for this purpose, to look for the MVI, and we know where the MVI forms, and near the pupillary margin, in the angle, I'm sure we can detect them before he goes to the next stage. And the close observation, as I said, and once there is MVI or MVA or new vessel on the retina, definitely not massage, but efficient and sufficient BRB. I added this recently, but this is what we were doing. Efficient and sufficient retinal photocoagulation to really barbecue, as I mentioned earlier, barbecue the retina and sacrificing most of the retina to preserve the central retina. This is the only way to really treat, to preserve vision, as well as to prevent the development of neovascular glaucoma if the patient is not already having the disease. And so this is our golden chance, really. It's a golden chance to give the appropriate or the care that the patient expected from us, to pick him early, an appropriate time if we have the chance, and give the appropriate treatment. And in this case, we can prevent or abort the development of this disease. Okay, established cases of neovascular glaucoma. It's already, he came to me whether referred from somewhere, or I failed to give him the appropriate treatment before he developed this disease, and he developed it, unfortunately. So now I'm dealing with an established case of a neovascular glaucoma. Our approach should be governed by the visual potential, how is the vision of the patient, and what is the clarity of the media. Is the media clear or not? And with this one, I found somebody took it from me also, but I did this many years ago, that and added some new things when the anti-VEGF became available. So I said, patient having an MVG, and we have to divide in two groups, either patient who has no light perception or patient who's with seeing eye, regardless what this vision is. 20/40, 20/20, counting finger, hand motion, is still a seeing eye. And this is a sick eye in a sick patient. You don't know what will happen to the other eye. So you have to serve this eye or try to salvage this eye as much as possible. If it is a seeing eye, we divide it, we look at, if there is a clear media, PRP at that time. Straight ahead. Of course, we'll give the anti-glaucoma medication, as you'll see, and then PRP, full PRP in multiple sessions. And nowadays, we were suffering when we have a patient with a clear media and good vision and pressure is high. We were admitting the patient, me and Professor Asra and Dr. Amro, in the hospital for 2 or 3 weeks. Inpatient at that time. This is in the late 90s. So we admit the patient and we give him full BRB over, for example, within a week or so, to give the full treatment in one session to avoid edema of the cerebral body, antichoroid, and so on. And then once the blood vessels disappeared from the iris, we subject him to the glaucoma or the filtering procedure or the surgical approach or surgical procedure or whatever. I mean, if he's good for trabeculectomy, we do trabeculectomy. Not suitable for trabeculectomy or there is a lot of risk factor, we go for tube surgery. But nowadays, of course, the implement of anti-VEGF, really, it relieved us and relieved the patient from being in the hospital for 2 or 3 weeks. Now, we can give a clear media, we give the anti-VEGF and PRP to be completed within few days, 2, 3, 4 days, 5 days, the patient is ready for surgical intervention if he needs surgery, and regardless of the type of surgery. So this is very important. If the media are poor, then we need to correct the media, correction of the media. In the past, before the anti-VEGF, if there is a cataract, we are in trouble. We do cryotherapy, unfortunately. And then we remove the cataract and complete the laser treatment. Sometimes we associate it with trabeculectomy. Nowadays, no. We poor media, we give anti-VEGF and correction of the media. If he has cataract, I will give anti-VEGF and wait for example, as I said, 3 or 4 days a week or so. And then we'll see, does he need a glaucoma surgery with cataract, or the cataract and the other eye is good and the cataract is not dense and he can wait for 6 months, no problem with that. It's not a cataract that you may push him to intumescent cataract and other type of glaucoma. So my practice or my preference is to go for glaucoma alone after anti-VEGF, and then I might need to repeat it, because we know that anti-VEGF is temporary effect. So I might need to repeat it and do the trabeculectomy or tube surgery, and then wait until the new channels that I created, until they get established, then we can subject him for cataract extraction and endo laser or whatever at that time, or even after that. Or sometimes we can combine the trabeculectomy or the glaucoma surgery with the cataract extraction if it is a cataract. If it is cornea, of course, we don't have much to do unless we have to evaluate the visual potential and and then we'll go and do a cryoablation and so on, and then BKB or whatever. So, and if the media problem is due to vitreous hemorrhage, which is not uncommon, then again, I will give anti-VEGF. I will deal with him as I dealt with this one, that he can wait for media correction for, say, months. Here also, the vitreous hemorrhage might go by itself, or the eye take care of this vitreous hemorrhage. But if it is persistent, then later on, after my filtration surgery or glaucoma surgery, he can be taken to be vitrectomized and to give the definitive treatment of the disease, which is PRP. So those cases are not suitable for trabeculectomy, again, we can go for tube shunt. This is our practice. We are not going to, as long there is a vision in this eye, whatever this vision, we don't do sacral procedure. We go for filtration surgery if there is a room for that. If not, we can go for shunt or glaucoma shunt procedures. Then if they fail, probably 1 or 2 shunts, we can probably apply the sacral procedure. In non-seeing eyes, as I mentioned, our aim here is to make the eye comfortable, not the patient is not bothered by his eye, and this can be achieved by medical treatment, steroid, beta blockers, atropine. And in most cases, they will respond and they will be happy, and you don't need to do further than that. If not, still the patient is in pain, you say, yeah, you may apply sacral procedure, and really, I don't remember for the last probably, I would say 20 years that I neglected an eye because of neovascular glaucoma. I don't remember, definitely. I'm sure about that. Okay. So what is the medical therapy? Of course, we have 2 problems now, the pain and inflammation and the elevated intraocular pressure. And pain and inflammation can be controlled by sarcoplegia, nothing better than atropine, and the steroid, topical steroid. And the elevated RUB, of course, aqueous suppressant with the beta blockers, acetazolamide, and so on. And again, steroid is mandatory. These eyes are, there is a breakdown of the aqueous-blood barrier, and there is inflamed eye, there is flare, there is cells, and so on. And we need to avoid myotics and the prostaglandins, and you know why you should avoid them. I don't want to say it. You know it. So this is a problem, really. Okay. So we avoid these myotics and the prostaglandins, and then once we started this in an emergency room, then again, in the same day or whatever, we need to inject the patient with anti-VEGF. This is the real treatment for, or rapid treatment, or I see it is a very, very important step to be taken to inject anti-VEGF, and you can start your pan-retinal photocoagulation based on the media and based on the situation of the patient or the case. And as I said, the BRB should be really a real BRB, booking again for the 3rd time the retina to really convert the hypoxic to anoxic retina. So the BRB is a different treatment, if possible, and as we mentioned, it reduces and eliminates the new visual formation in the anterior segment as well as in the back of the eye. Then we did all these maneuvers, and still the pressure is high or uncontrolled with medical treatment, after laser, after whatever, and the angle is open or is closed. It doesn't matter. So then we need to go for surgical intervention. And this, again, governed by the status of the eye. Is it suitable for filtration surgery? I mean, the conjunctiva is good. The eye hasn't been exposed to extensive surgical intervention. There is no much, you know, this is a syndrome, and we have it, almost syndrome, that there is no much surface problems in our in the eye, and this is a problem in our population, especially old population. They have shrinkage, conjunctival shrinkage syndrome and other problems, so the conjunctival and the conjunctival cell profile is surgery or trabeculectomy. If not, it's suitable due to any reason from that we have mentioned, then I think the best approach is to go for tube surgery and repeat it probably more than 1 time. If this is impossible, which is unlikely, then you can go for the whatever you want to do, sacral procedure or whatever. I hate it, really. So, and sacral procedure is not only in neovascular glaucoma, but also other types of glaucoma. It has a high rate of complication and visual loss. Cyclophotocoagulation associated with visual loss. This is old report. up to 46. And with the new machines, the new lasers, and the new development, still in 2010, they reported that even with anti-VEGF, they report visual loss up to 25%. So still, you cannot predict the results as well as the associated complication. Cyclocryotherapy, nobody doing it probably anymore nowadays, and it's well known to be associated with more risk for visual loss, phthisis bulbi, and so on. And so I don't think that is a modality of treatment nowadays. So then the tube surgery, I didn't touch the filtration surgery now, so suppose that the patient is not suitable for trabeculectomy, then I think the best approach to go for tube shunts. And again, tube shunts is giving a variable success rate, but it's a good option, to be honest with you. And probably more suitable for, as we mentioned, those who are not fit for filtration surgery. But again, we need to remember that the high rate of visual loss up to 48% and the phthisis bulbi up to 25% in these sick eyes. These are sick eyes in sick bodies. This is, of course, not the rate of this complication in ordinary glaucoma. Filtration surgery. In the remaining, I will take probably 5 minutes or so, then I will stop for the questions. I would like to share with you our approach or our practice at King Abdulaziz University Hospital. This was in the late 90s and up to now. This is our approach. So this is a very interesting study. It's a prospective study, as I told you. It is a full, it is reported 10 years ago, and it's a full band-retinal, preoperative band-retinal photocoagulation improves the outcome of trabeculectomy with mitomycin C for neovascular glaucoma before the era of to become a commercially available the anti-metabolites. Our cases, 30 eyes of 27 patients, the vision changing from hand motion, or gender is male more than females, and the age around, the mean age around 53, and the etiology, majority of them is due to diabetic retinopathy. And 7 of them only central vein occlusion, and 3 of them they already pseudophakic. So still, in pseudophakic patient with good conjunctiva, you can go for trabeculectomy. So the mean pre-op IUB was 41, ranging from 25 to 757, and majority of them, they have a closed angle, and the vision ranging from hand motion to 20/40. So even patients with hand motion, as I told you before, you don't know what will happen to the other eye, so you need to save this vision. And there is a difference when you are in glaucoma, and you see the difference between patient who's seeing light, those who are not seeing light. Not hand motion. Hand motion this is a luxurious sometimes in the glaucoma patient. So, and as I mentioned, 3 of them were pseudophakic. And the surgical technique is this usual one that we do it in ordinary glaucoma, trabeculectomy. But we have, with the mitomycin C 2.2 milligram per ml for 2 minutes, this is in all our cases, whether neovascular, uveitic, whatever. Some of our colleagues may use the mitomycin in a higher concentration and longer time. So, and the only thing that we pay attention to, usually these eyes are having high pressure. So you need to decompress the eye gradually. Sometimes you don't see, in slit lamp, you don't see fine vessels, especially with high pressure. So if you reduce the pressure when you go to do the trabecular opening from 40 or 30 or even less, and to 0, this will dilate and will rupture. In addition to the other problems, choroidal effusion and so on. So this is a routine in my practice. Even the pressure is 15 or so, always when I finish and wash the eye after mitomycin C, I go and do paracentesis, let some aqueous goes or leave the eye, and then utilize the time by putting my pre-placed sutures, the 2 corner sutures for the sclera flap, and then before they open, I go and after the first suture, I do again decompress further. When I put the second suture, I do decompress the further, and then I go and open or make my trabeculectomy opening or fistula. With less than 21, with medication failure, those who are not controlled with medication and the pressure is above 21. So our results after a mean follow-up of almost 3 years or even more, ranging from 6 months to almost 8, I think, or 9 years, I'm not sure. So the pre-op level, or the pre-op, the mean pre-op IUB reduced from 41 to 18, and the number of medication again reduced from 3 to 0.3, and all cases they have, also what we achieved complete success in 80% of cases. 80% after a mean follow-up of 3 years, 24 out of 30, and overall success was 90, 27, 3 eyes that needed further surgical intervention. And such results after 3 years, we don't achieve it in ordinary glaucoma. Why? Because these eyes, they are under more concerns to us or more care, looking for in the retina, in the glaucoma, looking for the blip, looking for the pressure, if they need suture lights, if they need injection, subconjunctival injection of mitomycin C, if they need massage, if there's any new MVI or whatever. So they are taking more care than ordinary cases. So such an outcome is really is changing our way of looking to a patient with neovascular glaucoma. I remember, I lived this feeling. When we see a patient with neovascular glaucoma in the late 80s and early 90s, يعني كنا نقول عليه السلام عليه السلام لنا. What we do is just to give a palliative treatment and waiting until if the eye needed to be enucleated or not. But nowadays, I swear that I haven't enucleated a single eye since, not referring them to oculoplastic or whatever, but I have experience in oculoplasty. I have 1 year, but I didn't need to send the patient for enucleation or so. So our result is really very promising, especially nowadays with the availability of anti-VEGF. So what are the short complications? It is as any glaucoma type. So, transient hypotony, hyphema, there is nothing specific actually, to be honest with you. Long-term complication, again, 2 cases progressed or the cataract has progressed, and when you look to the literature and look to the outcome of tube surgery or the trabeculectomy and so on, you will find that the NLB is a frequent findings, and hypotony maculopathy and phytis bulbi, none of them develop such a thing. And one of the authors, or who take care of the problems, Prof. and my teacher, and other teacher also, this is my teachers, by the way, Prof. Amro and Prof. Jadaan. So I'm discussing with them our cases that we have done. So none of our cases developed no light perception or hypotony maculopathy that need intervention, or none of them developed phthisis. So it is really, we are so happy, and this is the practice that we are doing up to now, except that the agony of patient and our agony by admitting patient for 2 or 3 weeks in the past, now with the introduction of anti-VEGF, we don't need. It is a matter of few days, and then the patient is ready for surgical intervention if you need to go for surgical intervention. So we concluded from this study that, yes, neovascular glaucoma is a preventable and treatable condition. You know, you remember Duke Elder what he said, and Grant what he says, and Hoskins what he said. This is in late 60s and early 70s. So now we are strongly believing that neoglaucoma is a preventable and a treatable condition, and anti-VEGF therapy has a central part in management and as an adjunctive therapy that all of you know that its effect is temporary. So the different treatment is proper, band-retinal, efficient and sufficient, barbecuing the retina, really. So efficient and sufficient BRB, which is very prerequisite, very important prerequisite for any successful, whether trabeculectomy or tube surgery, or even for the CBC that I don't like. So in summary, Yes, neovascular glaucoma is secondary, a common secondary glaucoma, whether an open angle or closed angle stage. And here, very important, there is no pupillary block in this condition. Sometimes I get sick when I see a patient with neovascular glaucoma has received, because they did gonioscopy and found that the angle is closed, he received or she received laser peripheral iridotomy. So no place for iridotomy in this condition. And most common causes are, as I said, diabetes, as well as vein occlusion, ischemic vein occlusion, and carotid occlusive diseases. And repeated gonioscopy is mandatory even in absence of MVI. And as I said, 10 to 12% of them, the angle vessels may precede the rubiosis or appearance of MVI before, or may precede the presence or the appearance of the MVI. So you need to do gonioscopy not only once in patient without, but even when you diagnose a patient with MVI and the neovascularization of the anterior segment, or even anterior neovascular glaucoma, again, you need to look after that, and he has already given the treatment to what you call suppress the neovascular formation. You need always to follow them and look for the vessels at the area of the pupillary area, as well as in the angle. So this is very important. And treating the underlying condition or disease is, again, a prerequisite for any successful surgical treatment, whether this is what probably I preceded in my mind. So underlying treatment of the underlying disease is important and the prerequisite for any successful procedure. So this is a patient who had a very nice blip, as you see here. Pressure is controlled, vision is good, but on follow-ups, you see the new vessels here or new vessels, so you need to take care and go and give him whatever suitable to suppress these new vessels. I'll stop here and answer a few questions if there's any questions. Thank you very much. What is the next step? Huh? No. Yeah. So our question, if you have a patient with uncontrolled glaucoma and you need to do, and you did for him or for her, a trabeculectomy, and the trabeculectomy has failed already, what is the next step? I will repeat trabeculectomy. If there, of course, when we do trabeculectomy, we don't go for 12 o'clock position. We try to go either superior tumoral or superior nasal, putting in mind that we might need the other quadrant for future procedure. So I will, in my practice, I will go for another trabeculectomy before I consider tube surgery. Yes?
Does ultrasound cycloplasty has a role in the
Very important question. He said, does ultrasound or UCB, cyclocoagulation, has a role in such conditions? Honestly, my way to look, it is a cyclodestructive procedure. So UCB or CBC or cryo, all the procedure, yes, probably they claim that UCB is less destructive to the adjacent tissues, but in my practice, I never consider any type of cyclodestructive procedure before I utilize exhausted, or the conventional surgical intervention exhausted. So I don't do it. I need to go for trabeculectomy once or twice, And if not, I will go for tube. If failed, probably I will go to UCB. In certain cases, I know this is being done even in the primary cases, as a primary procedure. I did it once to a very high VIB. But my aim is to delay his surgery. I know, and I told him that you need surgery. But his time is not suitable for him. So I know in Europe and even in our area here, they are doing UCB as a primary procedure in certain cases. And I'm not in agreement with that up to now. Until, although there are reports talking about this, until I see a very evidence-based that really it is an effective as a primary procedure, and yes, you can have this modality of treatment. But now I'm not convinced until now. But I believe it, I like it more than CBC. And probably the resident who are rotating with me, I can accommodate the cone for the UCB. I will prefer it even for the new generation of CBC. Okay. You can relax until the grand round. Thank you very much. Yeah, I would like to thank Prof. Amro and Dr. Jadaan. They are my teachers, really. He is my teacher not only in ophthalmology. Dr. Jadaan is glaucoma. Wallah, I'm serious. I'm serious. Yeah.
بسم الله الرحمن الرحيم. إذا بغيتوا تشوفون تواضع العظماء،
أيوة.
هذا أكبر دليل.
سبحان الله، ما يقدر عليك أبدا.
أبدا، لا صحيح والله، أنا أتكلم من جد. يعني يعني أنا أستحي من كثر ما يقول إنه I'm his teacher.
تستحق أكثر من كذا والله، الله يحفظك.
بعدين هو كان الله يذكره بالخير الدكتور هادي كان مع الدكتور
لا خريج مصر
من فترة مرة، هو اللي كان علمه ظاهر الانترا كابسولار كاتاراكت اكستراكشن والاي سي سي. فأنا كان معنا هو مع بالفيك والريفراكتيف، فيقول دكتور هادي أبو بكر he is my teacher in the old ophthalmology and me for the new one. فبس إذا يعني فعلا إذا الواحد يبغى يشوف أخلاق الكبار العلماء الباحثين البروفيسورز، فليكن قدوته الدكتور هادي.
I will take it out. ايه دكتور بيس حقه؟ لا هذا حقنا دكتور، بركب حقه الان. حاضر. دكتور ستورك؟
Just read the use of this little.
دكتور مرة.
Okay.
دكتور مرة, which way you want to? No. Or you want
Just accept the microphone and stay down because usually there is the podium there.
Yeah, we've been using it.
It's gone for it.
No, doctor. No. I'll bring you that outside. Dr. Peter, it's shown there.
Yeah. Perfect. Is it working? Yeah, great. Yeah. It's a big apple. How is Lyndon doing? Good?
He's doing very good. Very good indeed.
So often are you using Santa Barbara Alpha or?
I go probably.
So where do you pay taxes, in UK or in the US then?
Both.
Both? Oh,
Both.
That's bad.
It is bad. You're quite right there. Yeah.
That's the question. Where do you pay taxes?
Yeah, no. Unfortunately.
Well, with Trump now you pay less, right? You put them,
Sorry.
Trump reduced them basically, yeah? But
So taxes. Probably it's about the. Let's have a look.
just do your stuff. I'm just distracting you.
Yeah. Let me see. That's the one. I think that's the one. Yeah.
Is a director of translation? What? Translation of something? This is wrong.
Director of Translational Research.
Research, okay. So it's not that.
Right. Yes. There we go.
Okay. Just a separate mic from there because I'm not going to come up and down here, yeah? So, good afternoon, everybody. I think we can start. It's already past 2 o'clock with the Grand Round lecture. Today, we are pleased to introduce Professor Pete Coffey. He's the head of ocular biology and therapeutics at University College London, Institute of Ophthalmology, and co-executive director of a translational research center at Santa Barbara, Center for Stem Cell Biology and Engineering. He is the principal author and co-author of 2 landmark papers demonstrating the use of human cells to halt visual deterioration in models of age-related macular degeneration. His achievements include the launch of the London project to cure blindness, which will show us today, which aims to develop a stem cell therapy for the majority of all types of age-related macular degeneration, seminal work on retinal transplantation. Professor Coffey has received many honors and awards, including the prestigious Estelle Duini Living Tribute Award in 2009, Retinitis Pigmentosa International Vision Award in 2009, the CIRM Leadership Award in 2010, and the New York Stem Cell Foundation Robertson Prize in 2011. It's a great pleasure to meet to introduce him, and I hope you will enjoy the lecture. Thank you.
So thank you very much for the invitation to be here today. It's a great honour. It's been very good catching up with the research which is being developed, both in your stem cell environment and here, obviously, within ophthalmology. What I'd like to talk to you today is not what we published this year, which was the efforts of nearly 15 years' work, which was placing embryonic-derived RPE into the eyes of AMD patients. I am not going to talk about that today. I've been asked or tasked with actually giving you an overview of some new therapies or new technologies which I think are going to be important in ophthalmology. They will be important in trying to understand disease pathogenesis in eye disease, and also their possible use in finding new therapeutic avenues for treatments. So please feel free to interrupt or ask as many questions as you want at the end. So in our first transplantation studies, which was started in 2015 when we treated 2 patients, we were using stem cells which had been developed from fertilized blastocysts, fertilized embryos. We were locked down in that process in 2009. And then during that period, a new technology appeared, which was the possibility of producing a stem cell from your own bodies. So the London project was developed in 2007. In 2013, we got clinical trial approval for the 2 patients, which we treated in 2015, and we just reported in April. What I'm going to talk about today is that new technology. How can we actually produce a stem cell from ourselves? So, back in the 50s, there was, and still is, obviously, the concept that the pathway to our development and that blueprint of development is in our genetic code, in our genetic makeup. And that genetic code was essential in that normal development, in our birth, in forming our eyes, our lungs, our hearts, everything. But there was a dogma in the late 50s by both Briggs and King, 2 American scientists, who believed that that blueprint, that pathway to that pathway to our development was lost once we were born. So once we were born, how that genetic framework, how those genes interacted, that blueprint of how we develop was lost. But it was challenged. It was challenged by an individual, a graduate student at the time. So if there's any graduate students out there, you too can achieve this. He was a graduate student who challenged that concept. He was the first person to achieve something in which that genetic blueprint was transferred from an adult cell into a blastocyst. And what it further developed was the whole process which both Keith Campbell and Ian Wilmot were pioneers in, which was the whole area of cloning. So that genetic code of how we developed, what we became, did not disappear, was not lost when we were born, but is present in every single cell of our bodies, that blueprint. It was a further development in 2004 by Shinya Yamanaka, in which he therefore assumed that if that blueprint was still there in our developments, could we in some way reactivate it? Could we start that process of development again? And literally, he went from 24 genetic switches and found that all you had to do was turn on 4 of those switches. And suddenly, what you have is that embryonic type cell again. You have that starting cell back in your dish. But now, it's a copy of the cell prior to your birth. So it contains all the genetic material. And at the time, people believed the history of your development. Not surprisingly, both of those individuals then received the Nobel Prize in 2012. Probably one of the fastest Nobel Prizes for an individual, which was Shinya. It has now become a new movement in the terms of what and how can we use stem cells, not only for therapeutics, but can we actually use it for understanding disease pathogenesis. So what I'm interested in, what you yourselves are probably interested in, I'm taking a guess given that we're in an eye hospital, is eyes and retina. So now we really have the possibility of really trying to examine what happens when things go wrong in a number of cases and in a number of cell types of the eye, both in disease and in development. Because we have access to that patient's fault, which is in their genetic code, and the possibility of forming those cells which are diseased from a stem cell. So we now have a huge possibility to examine all the various layers of the retina which may be affected by disease and may result in the conditions which you, especially here in the clinical setting, are more than